And next up, we have David Monkawa, the co-chair of Save Our Seniors, a mainly Japanese-American health advocacy group opposing the evictions of elderly Japanese from their nursing home by Pacifica Company, and also a member of PANA. David is a former National Assistant Organizing Director for the California Nurses Association and NNU, and he contributed to NNU's national expansion. So take it away, David.
Hi, everybody. How you all doing? Thank you so much for joining us tonight. And I think we have some slides, right? Anyway, as Reggie said, I'm with Save Our Seniors, SOS. I'm the co-chair. And I wanted to start off with a quote from one of the people. This is Francine Imai. She's the former head of the Family Council at Sakura ICF. That's the nursing home where these folks are getting evicted. She said that a few of the residents were evicted as young children to go to concentration camps. Now they're being evicted again in the elder part of their lives. And it's very, very tragic. Among Asian Pacific Islanders, Japanese Americans have the most access to healthcare coverage. So we're fortunate in that sense, but we also have the most numbers of those over 65 years old. This is one of the top issues in our community. Pacifica is a for-profit international developer who is destroying an iconic nursing home to build market rate apartments. Originally, these nursing homes came about as a response to the racism that denied healthcare to most people of color, in this case, Japanese, for most of the past century, until about World War II. Whenever the government failed to promote basic needs like healthcare, our own communities had to engage in self-help and mutual aid efforts, such as forming money co-ops called Tanomoshi to build clinics and run social services. Eventually, they became nonprofits, but they could not compete with the private for-profits in a turbulent dog-eat-dog market. This is what happened to the original Japanese nursing home. That's why it was sold to Pacifica, like most all nonprofits. Today, about 80% of nursing homes are for-profit nationwide, as well as California. Over the past several months, this campaign has shown itself to be a poster child of how our current healthcare system is not capable of providing healthcare with justice. It's shown why AB 1400 is absolutely essential. After Pacifica announced its eviction plans, strange coincidences unfolded. The hot water went out. A few couldn't shower for days. Japanese food became substandard, and some patients refused to eat and suffered weight loss. 20% of the staff was fired without notice, and visitation remains restricted even as the pandemic clears. Managers also threatened, after the clear-out date, no one will be here for your loved ones except county staff. All of this is going on right now as we speak, forcing the remaining seniors out of the ICF. But the current laws are too weak, and there's zero enforcement mechanisms other than a slap on the wrist citations. Even though Pacifica could not offer any realistic viable relocation facilities for the residents to go to, the California Department of Health eventually approved the eviction plan. Moreover, they are the main opponents to a bill, AB 279, that would prohibit evictions and transfers from nursing homes during the pandemic. The Department of Health leaders literally received private phone calls from nursing home lobbyists, according to a Sacramento Bee article last year in February. The article remains undisputed by the department, by the way. Low-income folks on Medi-Cal are some of the most vulnerable seniors. My stepdad is one of them, currently in a nursing home permanently. He was turned down from Sakura Assisted Living due to them not having enough rooms. At the time, even though I learned there were some available rooms from someone inside, for each patient, Medi-Cal reimburses about $200 back to Pacifica, while Medicare patients receive $600, and COVID patients receive $850. That goes back to the institution. That is why nursing homes and hospitals always find excuses to not accept Medi-Cal patients. or kick them out afterwards somehow. These patients are the ones who typically need bilingual and bicultural care, which is a lifeline. It's not an amenity. These differences in reimbursement rates also encourages fraud and cheating by healthcare institutions in order to keep increasing their profits, since the cost of healthcare and drugs continue to rise. Pacifica was granted a COVID designation at 2 of its nursing homes, even though they had serious infractions before. KI LA had 105 deaths, the most in the Western United States. How did this happen? The community wants some answers. So I cannot let this evening go without commenting on what I believe to be the area with the most glaring deficiencies: mental health care for ATIs. In physical medicine, regardless of race, at least we share the same blood pressure, same temperature, same heart rate, and so on. But with 2/3 of Asians being immigrants, bilingual, bicultural healthcare workers are in short supply of mental health. Even rarer are those who have any understanding of the historical backgrounds of their immigrant patients or their US-born offsprings of immigrants. Professionals who treat Asians cite the model minority myth association with many symptoms of mental health, yet there is not much clinical studies of these psychological maladies. I participated in the union and patient care organizing drive excuse me, at the largest and only mental hospital that specialized in serving API patients during the mid-70s, located in LA's Chinatown. It was long since been shuttered and bought up by Kaiser. Women outnumbered men 3-2. One group of typical patients were the war brides from 3 Asian wars spanning about 40 years. Japanese, Korean, and Vietnamese women. They were war brides brought over by conquering US soldiers, mostly non-Asian and mostly white. And I'm not saying that all of these people were unhappy, but many of them were. My mom was a war bride, but she married a Japanese American soldier, my dad. These women face isolation in language, culture, community, and usually completely dependent on their husband's income and connections. One patient, her name was Khoi D'Alicio, a pretty Vietnamese woman with no teeth. Her husband had punched out her teeth, was being interviewed by a psychiatrist, and I was supposed to help interpret, even though I knew no Vietnamese. She asked me in broken English, why these men, the doctors, ask such personal questions about sex and families? Now, this is a woman who had seen her neighbors get strafed by US fighter jets and deeply feared anything military associated with authority figures. Another person, William, a Japanese American from Colorado, he's about 35, whose dad used to beat him and his sister if they showed too much attention to anything visually Japanese. His dad was in a US concentration camp and traumatized. The War Relocation Authority implemented the Loyalty and Americanization program in camps. And upon release, the WRA's 3 commandments were: speak English, avoid concentrations of Japanese, and keep your head low. William was getting a psych eval at Rest Haven, referred by the county sheriffs. He violently assaulted a sheriff in response to the mispronunciation of a coworker of mine. He hyperventilated and became aggressive, and I often wondered if his psychiatrist knew anything about the camps or anything else. So I thought that this type of thing would be an exciting organizing experience for I was right out of high school, and it turned out to be sort of a nightmare. So proper healthcare and fixing inequities will certainly require rethinking and reprioritization of our healthcare educational institutions. But I know that eventually we're going to win. And it's just a matter of time when you and I, all of us, are able to unite the many, defeat the few, and win healthcare equality for everyone. Thank you very much.
Thank you. Thank you, Reggie and Akeshi, Chansey, and David for sharing your testimonials and how the current profit-driven health insurance system has failed you, your families, and your communities. Your stories bring home the cruelty of a health insurance system that discriminates according to age, class, immigration and employment status, and ability to speak English. You've provided the ground level reality of what it means when you hear statistics let's say 2.7 million Californians are uninsured. Another 12 million who have health insurance are underinsured because they cannot afford to use the insurance they have paid for. And 5.2 Californians lack dental insurance. I mean, many of you probably know, or have done it yourself, going to Tijuana to get dental work done because you can't afford dentists in Los Angeles.